Items just to bring to everyone's attention. We have item number 20. We have 20 items on the agenda. Item number 2, Waldron, and item number 15, AB 2399 Nazarian and AB 73 Waldron were pulled. They're not going to be heard today. We have 4 consent items. Item number 3, AB 168, Manshine. You have other bills? Okay. Item number 4, AB 741 Williams. Item number 12, AB 2048 Gray. Item number 14, AB 2179 Gibson. Those are consent items. We're Senate Committee on Health. We don't have a quorum at this time. We're going to start off as a subcommittee. If we do get a quorum, I will interrupt. So because it's not often we get one, we'll try to hopefully not interrupt in the middle of testimony. Also, Senator Wolk will not be here today. We're going to take out of order because he requested, he had some individuals that needed to leave after this. So we're taking out of order and we're doing item number 10, AB 2004 first, Bloom, and after that we will go in order as members show up. So we can have item number 10, AB 2004, hearing aids, minors. And unfortunately, we still don't have a quorum, but if you like, please proceed. Please proceed.
Thank you, Mr. Chair and member. I'm presenting AB 2004. Early diagnosis and treatment of hearing loss with hearing aids has a significant impact on a child's speech and language development. Having access, therefore, to hearing aids is particularly important for children in classrooms, which makes this not just an issue of health care, but one of education equity as well. A child's ability to hear should not be determined by their family income, and I'm certain that we all agree on that. Yet, here in California, hundreds of families have to forgo hearing aids for their children, and thousands more have to pay the cost out of their own pockets. AB 2004 addresses this gap in coverage by requiring healthcare service plans and health insurance policies to include coverage for hearing aids for children. Hearing aids are accompanied by a number of services, including hearing assessments, replacement hearing aids, fittings, maintenance, and auditory training, all of which are essential and would be covered under this bill as well. The cost of a hearing aid is the most significant barrier to parents obtaining pediatric hearing aids. Hearing aids and hearing aid services cost an average of $3,500, which is an incredibly steep financial burden for working families. This bill would nearly double hearing aid coverage in California, increasing the number of children with coverage from approximately 5,800 to over 11,000. Additionally, 200 children would be able to get hearing aids for the first time. 20 other states already require health insurance to cover hearing aids for children, and it's time that California did so as well. Before I close, I'd like to address some of the concerns and questions that have been raised about this bill. The first concern is that setting an age limit on hearing aid coverage could constitute age discrimination under the Affordable Care Act. But last month, the Federal Department of Health and Human Services issued a final rule clarifying that state and federal mandates with age distinctions do not constitute age discrimination. Quoting directly from the final rule, age distinctions contained in federal, state, or local statutes or ordinances adopted by an elected general-purpose legislative body are not covered by the final rule. States may adopt new laws that contain age distinctions. These distinctions would not violate the final rule. That being said, should you allow this bill to move forward, I am committed to seeking out as much guidance and clarification from our state regulators and the federal government on the appropriate interpretation of the non-discrimination provision of the ACA. The second concern is that this bill exceeds essential health benefits and that we should be adding hearing aid coverage through the EHB benchmark plan. The goal of having hearing aids covered through the benchmark plan is not mutually exclusive with this bill, in my opinion. In fact, this bill includes language directing the state to explore other ways of ensuring pediatric hearing aid coverage, and one such option is picking a new benchmark that includes hearing aid coverage. Now, if we believe that California children should have access to these medically necessary devices, we need to make hearing aids a priority, and we cannot wait or depend on the EHB process exclusively. AB 2004 will ensure that all California children, regardless of income or background, have health insurance coverage for hearing aids. Testifying in support of this bill are Sherry Farina from NorCal Services for Deaf and Hard of Hearing, as well as Heather Louder-Clay and Charlotte Furtado, both of whom are parents of children with hearing aids and who, if I'm not mistaken, have brought their children with them.
Thank you very much. Those who are going to testify, please state your name and proceed.
Yes, hi. I'm Sherry Farina from the CEO of NorCal Services for Deaf and Hard of Hearing. And I am here representing the California Coalition of Agencies for the Deaf and Hard of Hearing, and we provide direct services throughout the entire state of California, all 58 counties. And I am also representing the California Association of the Deaf, as it's a membership organization. And all of our organizations are in support of this bill. We have seen firsthand the struggle that families are going through, trying to find a way to come up with the money in order to buy hearing aids for their children. And this is not the first time that this effort has come to fruition. In the past, we have tried to have this come to fruition, but it has been blocked by special interest groups and other people who lobbied against it. So we're hoping that this is going to be the time that it's going to be able to be pushed through, because it is a long overdue movement. Children, they deserve and need services that hearing aids can offer them. Now, there are some places that do try to offer free hearing aids, but the families are required to be paraded in order for PR purposes in order to get a free hearing aid. So that's really not the right way to be getting hearing aids for your children. And ensuring health insurance coverage for hearing aids is extremely critical, and it is the only way that families are going to be able to get hearing aids for their children, and because many families are not able to pay for it out of pocket. They can't afford it. So thank you very much for letting me speak.
Thank you. Anyone else in support?
My name is Heather Louder-Clay, and I'm the mother of Iris, and I'm in support. My daughter was diagnosed with moderate hearing loss in her right ear at age 4. I remember calling my mom crying, what would this mean for Iris? Would she be able to hear the ocean, the birds, music? She loved to dance. At that time, I wasn't even thinking about language or school or the impact that hearing loss may have upon her development and learning. Later, I learned that even with moderate hearing loss, a child can have not only learning challenges, but behavioral and social, if they're not able to hear their family, friends, teachers, and others. After receiving the diagnosis, we were told that Iris would benefit from a hearing aid and that it would restore her hearing to an almost normal level. We met with the audiologist and began the process for obtaining a hearing aid. I naively expected that it would be covered by our insurance. When I talked with our insurance company, I was told that the $2,400 hearing aid would not be covered. I asked, is a prosthetic leg covered? Yes. I asked, isn't a hearing aid similar to a prosthetic leg in that a hearing aid helps a child hear, just as a prosthetic leg helps a child to walk? No answer. I'm sorry, but your child's hearing aid is not covered under this insurance plan. For a child with hearing loss, a hearing aid is just as important as a prosthetic leg is to a child who can't walk. In both cases, the devices assist a child to fully blossom into their full potential. Without this assistance, they're at an immediate disadvantage over their peers. This year, my daughter began kindergarten. By having a hearing aid, it allowed her to access a system called FM, A teacher speaks into a microphone which directly transmits the teacher's voice into my daughter's ear. I can't imagine what school would be like for Iris if she didn't have the assistance of her hearing aid. I am grateful that my daughter has a hearing aid that restores her hearing to a normal level. We were able to receive this for our daughter. However, other families are not able to afford this healthcare cost for their children. Every child with hearing loss deserves this device, which makes all the difference in the world. We ask that you support AB 2004 so that insurance plans cover the cost of a hearing aid for every child. All children deserve to hear the birds, ocean, and music and fully blossom. Thank you.
Thank you. Anyone else in support?
Yes, my name is Charlotte Furtado, and I too am a mother of a 5-year-old who is hard of hearing. She has one hearing aid, and we discovered her hearing loss through the newborn screening program. So she was born premature, and then even before her due date, we knew that we could do some interventions. So as we started down the process, I found out that my insurance policy, which that year I paid over $16,000 in premiums for, didn't cover this item my daughter needed. And she needed it for communication growth, for every important language development, social, economic, everything is tied to your ability to hear and communicate. One of the things that also was frustrating with the process is not only did my insurance not cover my $2,400 hearing aid and all of the molds, so because she was an infant, every 2 months we had to go back to the audiologist and get a new mold, another $100 out of pocket every visit. So not only did I have twins, I had twins going to specialists, paying out of pocket for visits. Mind you, I paid a lot of money for my insurance, and none of this counted towards my deductible. So it was considered elective. So somewhere in the insurance policy, a hearing aid is equated to something like liposuction, and that is really just not right. Do you want to talk about your hearing aid?
Thank you. If we can state your name and position?
Gabriella? Okay. You ready? Need a little help? Here. I can still hear you. Say hi, I'm Gabriella.
Hi, I'm Gabriella.
And you want to talk about your hearing aid? What color is it?
My hearing aid is pink on the top and the mold is blue.
And do you want to say, does it help you hear?
It helps me hear. And I have one.
Can you say thank you? Do you want to say anything else?
Thank you very much. Appreciate that. That's better testimony than I've ever heard in a long time.
Could you call for a vote now, Senator?
Well, I don't have a quorum, otherwise I would, so. Anyway, anyone else in support?
Vanessa Kahina on behalf of the Hearing Healthcare Providers of California, here in strong support.
Shireen Walter, representing California State PTA, the Parent Teacher Association, in support.
Judy Darnell on behalf of United Ways of California, in support.
Jacqueline Zanowski on behalf of Disability Rights California, in support.
Sarah Lindner on behalf of the National Association of Social Workers, in support.
Cynthia Clark, I've been a speech-language pathologist for 33 years and have seen what havoc is wreaked if students have not access to early hearing in terms of their reading skills. The cost to taxpayers ultimately for special education services is astronomical because of something that we can fix. Thank you.
Jonathan Clay in support.
Opposition, please?
Good
Good afternoon, members of the committee. I'm Jennifer Alley with the California Association of Health Plans. And last year, legislators made a choice for the essential health benefit plan that would be selected for the state. And that coverage did not include hearing aids. Exceeding the essential health benefits, this would be the first time that the legislature would actually take that action. And we are obviously concerned that enacting new mandates that exceed the EHBs outside of the legislative process and selecting would be a problem, become a slippery slope. As of now, our plans have already filed their products and began submitting their rates for the 2017 benefit year, and that would not include this additional benefit. And we need to be cautious and take considerations as, protections for plans included in the implementation of the ACA are being phased out this year. Our opposition is mainly due to the process and protecting the integrity of the EHB and the work that goes in maintaining the affordability of health care coverage for all Californians. And for that, we are respectively opposed. Thank you.
Thank you. Anyone else in opposition?
Stephanie Watkins on behalf of the Association of California Life and Health Insurance Companies. Unfortunately, we are here today to oppose to this bill. This is probably one of my least favorite bills I've had to testify on all year. We absolutely understand the need and the desire for these folks to have coverage. Unfortunately, there is a process, as my colleague referenced, and we believe that this would be more appropriately discussed as a part of that process when we reevaluate the HBs at a later date when we resubmit those. So for those reasons, we are opposed to the bill. Thank you.
Thank you. Anyone else in opposition?
Yeah, John Winger on behalf of America's Health Insurance Plans, also opposed for the reasons previously stated.
Thank you. Questions, comments from any of the members? Senator Nguyen?
Assemblyman, I guess it perks my interest of what the opposition said. What process and when does that take place the next time?
Well, there is no date scheduled for a follow-up process, but it is anticipated that at some point in the future, essential health benefits will be recalibrated and reset.
Who sets that date? Who does it? Do we do as a legislator, or maybe some?
I'm not sure.
I can answer that.
I think the chair is knowledgeable.
So when we first did the essential health benefits is when the Affordable Care Act was put into place. We based it on various different types of plans. We voted for it as the legislature. We just recently updated or reauthorized it, and we reauthorized, I believe it was the Kaiser Small Group. And if I'm not mistaken, I don't know how you voted on it, but you voted on it, and that was the process as well, which was last year. Then what we have to do is we have to wait for the federal government, again, to determine when we can reset those. And during that process, everything is on the table from, whether it's classes or acupuncture or whatever, but this will be the first time if the legislature were to pass and the governor would sign it, we'd have something outside of the essential health, the HBs. So, but there has been a process.
Thank you. Thank you. I'm just a comment then. I will be supporting this. I've in previous years I've always been supportive of trying to get eyeglasses, dental care for children, because essentially those are very needed for them, because children don't know if they can see clearly, they don't know the difference, or they don't know what a toothache is. And I've said it over many times here. I've got a 5 and a 3, and actually my 5-year-old went through an extensive hearing testings. We're blessed that he didn't have to get into a hearing aid, but it took us quite a bit, and he's done really well. But I appreciate, and I completely understand the opposition. This is not something that I normally would do, to go outside of our normal process, but I think that I don't want these children to wait a year or two or whenever that would take place, and so I will be supporting it.
Okay, see no other questions or comments? Again, unfortunately, we do not have a quorum. Would you like to close?
Thank you, Mr. Chair. Let me point out that we do cleanup legislation around here all day long, where we realize later that a mistake was made. This was more than an error. This is an inequity. It has provided for inequity in healthcare and inequity in education. More than anything, this is a place where we do justice. And I think we all agree that this is that should be our ultimate goal in the legislature. So I respectfully request that this committee allow this bill to move forward so that we can achieve equity in both healthcare and education on this very important issue for this very important group of people.
Thank you. When we do get a quorum, we'll address the issue and thank the individuals who came to spoke. Hopefully they can make their flight in time, especially the little girl. She was adorable.
Thank you.
Okay, we're now going to go back onto calendar. We're at item number 1, AB 72 Bonta, healthcare coverage, out-of-network coverage. Morning, Assembly Member. Good afternoon. Sorry.
Good afternoon, Mr. Chair and colleagues. I'm pleased to present to you AB 72 today. We're back with a proposed solution on surprise bills, which is one of the biggest consumer problems that we have in our healthcare system today. This is a strong consumer protection bill, and it represents a year and a half of work with multiple stakeholders, multiple colleagues, and now multiple, I'm proud to say, multiple joint authors. AB 72 ensures that patients pay only the in-network cost sharing when the patient goes to an in-network facility for a procedure, and unbeknownst to the patient, an out-of-network provider participates in their care. Almost everyone has experienced, heard of, or knows someone who has experienced a surprise bill, and many of you know how expensive some of these bills can be. So this is a critical consumer protection issue that we are proud to bring a proposed solution forward on today. By requiring that the patient pay only the in-network cost sharing, the patient pays the same cost that the patient would have paid to the physician for covered benefits if the physician was in-network. In addition, this bill puts in place what we believe is an appropriate payment standard for the providers. That was an issue of much discussion and dispute last year, and we've arrived at a different place. You might recall AB 533 provided an initial payment of 100% of Medicare. Our proposal in AB 72 takes a two-pronged approach whereby the provider will receive the higher of 125% of Medicare or the average contracted rate. We think that that is a more balanced proposal and a stronger proposal. AB 72 requires the plan, so we've had many discussions with stakeholders on this important issue. We think we're closer than we've ever been to a solution. We continue to be open-minded as we move forward. I know that there'll be some raising of concerns today, and we continue to be open to providing solutions to problems that are identified, and we have the summer to work through some of those. This bill, I'm proud to say, enjoys broad bipartisan support, and in particular, I'm very proud that we have a number of my colleagues in the Assembly have joined as co-authors, as joint authors. Dr. Wood, our Assembly Health Chair, is with me today, and he's prepared to make a few comments and also answer questions. I'm proud that he's a joint author, and also our Assembly Health Vice Chair, Brian Mainshine, is a joint author. We also have Assembly members Dali, Gonzalez, Bonilla, and Santiago, who have all joined as joint authors as well. I think that shows the growing momentum behind the bill, the building desire to once and for all craft and provide a solution to this challenge. And we also have with me our sponsors, who I'm proud to have as sponsors on this bill. Tam Ma will be speaking for Health Access. I also have Sarah Flocks for the California Labor Federation, and Beth Capel from Health Access is here as well to answer questions. But first, I'd like to turn it over to my joint authors, Assembly members, Brian Mainshine, and our Assembly Chair, Dr. Wood, to make a few comments.
Thank you.
Thank you, Assemblymember Bonta, Mr. Chairman and members. AB 72 is the culmination of many months of meetings and extensive discussion between members, staff, and stakeholders. It was agreed from the beginning that the consumer had to be the ultimate winner in this debate, and the bill had to reflect as close to an equal compromise as possible. The current version of AB 72 is a significant improvement from AB 533 due to the collaboration between Assembly Democrats and Republicans to ensure balance. The version in print is still a work in progress. However, the proposed amendments we are taking today further improve on what we have completed thus far. We are committed to continuing to address the problem of surprise billing and believe we can finalize the last few sticking points before a floor vote. I would now like to turn it over to my Assemblymember Wood for further comment.
Thank you. Thank you to my fellow members. I just want to thank the chair for his work and his staff working on this issue with us. We believe it is imperative that we protect the consumer. That is what has been our primary concern from the very beginning. But it also needs to be fair and balanced between the other stakeholders in this. And we believe, I personally believed in my involvement that 533 left a little bit of an imbalance. I think we're much closer to a balance that is fair, and look forward to continuing to work on this issue. Thank you.
Just real quick, before we move on, I think you said you were going to take the amendments with a mock-up that's in the analysis here that you're presenting. Is that correct?
Just to clarify, those are the author's amendments from last week? Yes.
Okay, just want to make sure. Okay, anyone else you still have more testimony?
No, we have a witness testimony if the chair desires.
Yes. Well, what if I don't? Is that okay or not? I guess I'll let you guys go. Of course, welcome, and please proceed.
Good afternoon, Mr. Chair and members. My name is Tam Mon. I'm with Health Access California. Just want to first start off by thanking our 7 joint authors and all of the work and time that they have put into protecting consumers from surprise medical bills. I think it's fair to say that all of these authors have spent more time in meetings and thinking about this issue than they have on their own bills, and for that we are very, very thankful and very grateful. I also want to thank you, Dr. Hernandez, and members of the committee who have supported our past efforts to address this issue. Health Access is pleased to co-sponsor this bill, which will hold consumers harmless for surprise medical bills when consumers do the right thing by going to an in-network facility. AB 72 is a much better bill than the one that you heard last year, and it provides much stronger consumer protections. Consumers know that they have to follow their health plan's rules and go to in-network providers to keep their out-of-pocket costs under control. However, even the most careful consumers can end up with a surprise medical bill when they go to an in-network facility, such as a hospital or a lab, and end up getting seen by an out-of-network doctor that they did not pick, did not choose, and have no control over. We have heard from hundreds of Californians who have gotten a surprise medical bill for hundreds or thousands of dollars from an anesthesiologist, a radiologist, or pathologist, or an assistant surgeon that they either barely met or never met at all, didn't choose, and have no control over. Just last month, the Federal Reserve said that nearly half of U.S. households would have trouble meeting an emergency expense of $400. So a surprise medical bill is a real hardship for California's working families. AB 72 holds consumers harmless when they get care at an in-network facility by letting them pay in-network cost sharing that they would have paid for the in-network care if they ended up getting treated by an out-of-network doctor. This bill has stronger consumer protections compared to last year's version. AB 72 places limits on debt collection and prohibits wage garnishment and liens on homes. And as Mr. Bonta stated, this bill has a higher payment standard for out-of-network doctors. AB 72 requires health plans to pay non-contracting doctors the higher of 125% of Medicare or the average contracted rate. The average is based on the commercial rates and does not include Medi-Cal rates. And per the request of the California Medical Association, the average contracted rate is locked in at the 2015 levels so that plans can't game what these rates are. The average contracted rate also includes an escalator, which at this point is based on the Consumer Price Index for medical services. The language also requires that the average include both the highest and lowest rates paid. And just like last year's bill, doctors who wish to be paid more than the standard that is in the bill can still appeal to an independent dispute resolution process, which now includes strong conflict of interest standards, as well as allows doctors to bundle claims. We have taken, as co-sponsors, we have agreed to a number of amendments that the CMA has indicated that were very important to them, and these amendments make AB 72 a much stronger bill. We're committed to working with our joint authors and with this committee and with all the stakeholders to continue refining this bill and getting to a place where we can send a bill to the governor and protect consumers from surprise medical bills once and for all. On behalf of Health Access, just respectfully ask for your aye vote on this bill, and thank you for your consideration of this measure.
Thank you. Anyone else in support?
Mr. Chair, members, Sarah Flox from the California Labor Federation. We've come on as a co-sponsor of the bill this year, and just wanted to thank the joint authors for all of their hard work and their expertise and all the time they spent grappling with this issue. We came on to this bill as a co-sponsor because as AB 533 was moving through the process last year, we started to get calls from union leaders. And they told us that surprise bills was one of the #1 issues they were seeing in front of appeals committees for our trust funds. And I was honestly quite shocked because our members we negotiate some of the best health coverage that we possibly can. We have programs to encourage people and teach people to use their benefits to really try to control costs. And with the amount that our members are paying out of pocket for health coverage, it was especially painful, I think, for union leaders to see that they have members getting bills that are up to $10,000, $15,000 when they've done the right thing. And so we were asked to come on as a co-sponsor of this bill. So we are very happy about the consumer protections. We represent consumers, but in this process, we are also purchasers, we're payers. And so it was very important to us to see that there was a fair and reasonable payment standard, one where doctors were able to get a fair rate for the work that they've done, that there was a process, so there would be appeals, so that there would be a structure for this process, and one that was very transparent, but one that also made sure that we were not going to be facing reimbursements that would drive up our premiums. And so we are very happy with the bill and with the amendments that are being proposed by the joint authors. We think this is an incredible piece of work. It has been an honor to be a part of this process, and we would urge your support for the bill. Thank you.
We're going to interrupt for a second. We've got to establish a quorum. Call the members, please.
Hernandez?
Here.
Hernandez here. Nguyen? Here. Nguyen here. Hall? Mitchell? Monning? Nielsen? Here. Nielsen here. Pan? Here. Pan here. Roth? Roth here, Wolk.
Quorum has been established. I believe this is the testimony for support. These are the in-between, so we're going to go with support over there. If you can do name and organization only, and then we'll go to, I believe, the concerns.
Emily Rush, on behalf of CalPERG and Strong Support, and just want to extend our thanks to the authors and sponsors as well for all their hard work.
Michelle Cabrera with SEIU California, also in strong support.
Brenda Diaz on behalf of California Coverage and Health Initiatives and the Children's Coverage Coalition.
Elizabeth Landsberg with the Western Center on Law and Poverty in strong support of these strong consumer protections.
Dolores Dorian Flores with the California School Employees Association in support. Megan Brightwell on behalf of the California Professional Firefighters in support.
Jasmine Gordon with the California Black Health Network in support.
Kimberly Chen with the California Pan-Ethnic Health Network in support.
Autumn Ogden with the American Cancer Society Cancer Action Network, also in support.
Gina De Silva with the California Immigrant Policy Center in support.
Mr. Chair and members, Mike Belote for the California Association of Health Underwriters in support. Thank you.
Kieran Savage, National Alliance on Mental Illness of California in support.
Stuart Ferrer with the National Multiple Sclerosis Society in support.
Mike Montgomery, Congress of California Seniors. We support the bill.
Judy Darnell on behalf of United Ways of California in support.
Aaron Fox, the Los Angeles LGBT Center in support.
Now, concerns first and then opposition.
Thank you, Mr. Chair and members. Nick Luizos with the California Association of Health Plans. As members know, California's health plans and carriers have long opposed the practice of balanced billing, and we certainly share the consumer group's frustration with surprise medical bills. Our association was among a diverse group of supporters for last year's AB 533. And we appreciate the attention to this issue and the tremendous efforts that the author and the other members have put forth on this important issue. I'm certainly trying to thread the needle and patch together all of the warring clans on this issue can be no easy task. And this issue's been around for a long time, and there's a lot of history on it. Our basic position is that the consumer should not be put in the middle when providers do not contract with plans. We wholeheartedly agree that we need to ensure the proper consumer protections are in place while also encouraging physician participation in health plan networks. And it's around this concept, among others, that we have issued a letter of concerns about this particular bill. And if the bill moves today, our industry wants to remain a key part of the discussion so that our issues can be properly addressed. And we laud the author's efforts here with a sincere attempt to protect consumers. However, we do believe that some changes could be made to the bill to improve the workability of the bill, hold down out-of-network costs to enrollees as much as possible, and to encourage, not discourage, contracting between plans and providers. Because when plans and providers do contract, they are inherently, the consumer protections are inherently in place that ban balance billing and other practices. As currently drafted, we do view some of the provisions of the bill as unworkable and will unintentionally increase costs and establish a payment structure that over the longer term we think makes contracting less attractive. So we want to be a part of the solution. We've feel that our industry, our side of the equation has demonstrated a willingness to be flexible and have demonstrated the ability to move on this issue. And indeed, there's been a lot of movement on this issue in favor of the provider side of this debate. And while we have demonstrated flexibility and the willingness to move on some of these concepts, we do believe that further refinements are necessary to the bill. And my colleague with the Association of California Life and Health Insurance Companies will explain some of those issues in more detail.
Good afternoon. Stephanie Watkins on behalf of the Association of California Life and Health Insurance Companies. We too applaud the author and sponsor. This has been an iterative and long process for all of us. I think we are generally supportive of the concepts that we've seen today. We do have some outstanding concerns, and they really are about the workability. Specific to this bill, the details are incredibly important, and I'd just like to point out a couple of those for the committee to consider. One being the current definition of average contracted rates. We believe it's vague and needs to be more clearly defined. We believe the average contracted rate should be further clarified to reflect that it is intended to be the straight average of plan contracts. This is a critical clarification as we want to ensure that the average contracted rate is not developed in a manner that unduly drives up costs to the system. As such, we are also concerned for this year, after the annual contract rates are reported, the bill requires health plans and insurers to adjust the rate by the Consumer Price Index for medical services. Since 2006, the CPI for medical services has seen only growth. So this CPI inflator will in effect impose an automatic increase in what plans may pay providers regardless of what is negotiated in provider contracts. This is certainly a concern for us as we want to ensure that the contracted rates are a true reflection of what the market is currently paying for those services. If you choose to tie the average contracted rate to the medical CPI inflator, this new reimbursement rate will no longer accurately reflect the average contracted rates and will automatically increase costs to the system year over year. Just to give you an example, over the last 10 years, the medical CPI grew as much as 3 times higher than the average CPI. It's truly important to understand the health plans and insurers manage costs through negotiating with providers to provide services through contracted high-value networks. Annual negotiations may result in an increased reimbursement rate for providers, but it does not necessarily equal what the CPI would. The provisions in this legislation will harm consumers and insurers if it creates an environment where there is no incentive to enter into a mutually beneficial provider health plan contract. It only creates a perverse incentive for providers to remain non-contracted in order to game the system that would automatically increase provider reimbursement based on nothing to do with the quality of care provided or what is reflective of the true market costs. Instead of adjusting the annual contracted rate using the medical CPI, we believe that the set rate should be tied to the annual Medicare fee schedule, which more closely aligns itself to what is actually being paid in the marketplace specific to services. Arbitrarily tying the contracted rate to an inflator that automatically increases provider reimbursements at a rate faster than the true market conditions would contradict the bill's intent to base reimbursement of non-contracting providers on actual market prices. We truly understand the importance of this legislation to our members. We strongly encourage this committee, if this bill moves forward, that it does so on the condition that these issues are addressed in the coming weeks while we're on break to ensure that the changes and the patients are benefited by the protection of a ban on balanced billing, but ultimately consumers don't pay for that in additional premium dollars. So as my colleagues have said, we certainly want to continue to work on this. We want to continue to open the dialogue and to address these issues as the bill moves. Thank you.
Thank you. We still need for the opposition to speak. If I can ask that you just limit your comment to something that has not been covered, unless you have, or just add something that you knew.
Well, I'll just add, Mr. Chair, David Gonzalez on behalf of CAPG. Our providers are responsible for the care of some 20 million patients. I want to thank the joint authors and the co-sponsors for their hours and hours of work in negotiating this. We do have concerns on the CPI reference, which is in your analysis on page 12 under C, but we think the conversations are going in the right direction and hope they can continue. Thank you.
Thank you. If we can make room for the opposition, the true.
I heard you text one person like last week. It's,
Mr. Chair, one additional concern. Doug Chiapetta on behalf of the Union of American Physicians and Dentists would ask me one matter that was not addressed in the concerns part of the discussion. The rate setting provisions in the legislation are of concern to us with respect to collective bargaining implications. These surveys and studies are looked at by us when we go to negotiations with the state and other elements of the public sector as to what's going on in the private sector. So the concern is, although the bill is limited with respect to private sector doctors and specialists, that it not constrain our salary surveys as it relates to collective bargaining for our private sector doctors. With that, I'll conclude. Thank you.
Thank you. And what's remaining is opposition. We haven't kept any time, but we can try to keep it similar to what the proponents did, and obviously what the in-betweeners did. But anyway, please proceed.
Mr. Chair and members, Stuart Thompson on behalf of the California Medical Association. I'd like to echo the statements of the previous witnesses regarding the amount of work that the authors and especially their staff have put in their issues. So we are incredibly thankful for that and their attention to this issue. We think we were quite close on the AB 72, the language that went into print. The recent amendments do take out a provision we thought made the equation balanced, and that provision was the insurer in this scenario would collect the copay and the deductible from the patient, and we thought that was important for two reasons. One, in that scenario, the patient would never have gotten a bill from the physician, and so if we're truly trying to solve the surprise billing issue, we thought that would be one way to solve some of the confusion that sometimes happens with medical billing. The second is there's some talk regarding the payment metrics, the higher of the 125% of Medicare and the average contracted rate. Those two payment metrics, in my recollection of the discussions, were the two that it seemed to be the health plans and the proponents were comfortable with. And so for us, we felt like by agreeing to those two payment metrics, the bill should include some other balancing provisions that made this a fair deal. So we were quite close. We did have some concerns regarding the bill in print, but with those amendments, we do have some greater concerns going forward. I just want to briefly, kind of from our perspective, explain what we think AB 72 will do to the current market. When you set out-of-network rates for physicians that are non-contracted, this is a statutory rate. Basically, if an insurer and a physician can't reach agreement, the insurer knows exactly what they'll have to pay if they don't sign a contract. So we believe, given the current network adequacy laws, there's actually no specific law or requirement that a health plan has to contract with a hospital-based specialist at a certain facility. The requirements are actually geographically and time-based. So we believe that this sets up a scenario whereby an insurer can be contracted with the hospital, but actually not have any in-network providers, the hospital-based specialties, working at that facility. So that would kind of be one of the concerns that we would hope to continue discussing in July as to what requirements would the health plan be to contract, because we believe once you set the default rate at these two payment metrics, there's certainty for the health plans, which is something that they like in determining their premium rates, and it really will discourage contracting at payment rates above the statutory rate. Regarding the bill and print, we do share some similar concerns around how we determine the average contracted rate. We believe currently in the bill, it's a little subjective. It's not exactly clear as how we're going to reach that rate, but CMA believes that it should reflect the average in-network rate paid for a certain service. So in that regard, I think during some of these stakeholder discussions, there was talk about weighting contracts that represent different numbers of physician groups equally, and we'd obviously have a problem with that. We think it's quite simple to look at the total number of expenditure spent kind of per CPT code and then divide that by frequency, and there's an equation where you can get the average actual in-network rate paid to a given provider for a certain CPT code. So those are kind of the discussions that we look forward to having. Again, we'd like to thank the authors and the sponsor. And we will continue going forward in these stakeholder negotiations and hopefully reach a resolution